I'm starting the live stream, waiting for it to pick up here. Hi, Eileen. Hi, Judy. Okay, and here comes the Vimeo. And then I'm going to close it before it starts making noise. Okay. We're live. I can't seem to move my, having weird screen problems. Come on, there we go, okay. Okay, I think maybe we will get started. Welcome everybody to the quarantine-ish book talk hosted by the Jewish Women's Archive and jewishLIVE. I'm Judith Rosenbaum, the CEO of JWA, and I am so glad to be with all of you tonight for what I know will be a really thought-provoking conversation. Thank you so much for joining us. Thank you to those who are introducing yourselves in the chat box. Please continue to do so. We'd love to know who's with us this evening. And also, you should add your questions in the chat box as the conversation continues, and I will be bringing them into our discussion here in the second half of the program. I am so delighted to be in conversation tonight with Dr. Chavi Karkowsky, who is a specialist in maternal fetal medicine in New York City. And she's also a writer, obviously, because we're featuring her book, High Risk, which is fabulous. And she's also published many, many wonderful essays in Slate and The Atlantic and The Washington Post and many other places. Welcome, Chavi. How are you doing tonight?
I am doing great. I'm really happy to be here.
I am so glad that you're here with me. And I'm really excited to talk about this book, which I absolutely loved. I don't know if, I feel like maybe years ago we talked about the fact that probably nobody on this call knows this, but I wrote my dissertation actually about the women's health movement. And there was a time, both in graduate school when I was not enjoying graduate school and afterwards, where I thought very seriously about going back to school to become a midwife. So this touches on many things that I have had an interest in for many, many years. But tell us a little bit about your work, because I'm sure for many people, maternal fetal medicine specialist doesn't necessarily bring to mind a lot of specifics. Tell us a little bit about what it means to be an MFM specialist.
Yeah, you're not alone. Actually, a lot of doctors don't know what we do. One of the things about actually working in women's health and working in pregnancy care is sort of how segregated we are so quickly. So I am an OBGYN. I went to medical school. I did a residency in Boston, and then I was actually a generalist in Cambridge, Massachusetts. I was an OBGYN, and then I decided that I missed sort of the adrenaline of the really, really high risk cases. And so I did a fellowship. So I did 3 more years of training where I learned how to take care of women who are sick in pregnancy, where high-risk pregnancies that are sick because of the pregnancy. And then that's the maternal part. And the fetal part is that we are the specialists in diagnostic fetal ultrasound. So if you remember, if you've ever been pregnant, if you have that 20-week scan where we check all the fingers and the toes and the heart, somebody like me either came into the room or was checking all the pictures behind. So I have those aspects of my job: high-risk mom, high-risk baby.
And so how in the midst of all that did you manage to write a book? Most doctors don't write books. So how did this book get birthed in the midst of all the other birthing that you are in charge of?
I will tell you this. I feel like one of the things about my job that is both wonderful but also can be a lot is that I really feel like I'm in the room for some of the most compelling stories of the human experience. I sometimes say, like, the big things that we experience as humans are like birth, death, love, and sex, right? And I'm kind of in the room when like the culmination of all of those things happens at the same time. I say that people think about birth and pregnancy as happy events, and so often they are, but I also see stories of tragedy, but I also see stories of betrayal and like tremendous courage and really like surpassing love. So because I do this work, it's not just like an amazing story that I want to share once a day or once a week. I live in like a tsunami of stories. And I think actually for the first like 10 years of my medical career, I just sort of stood there and let them wash over me. I didn't have the wherewithal to do anything with them. And then at some point it became really hard for me not to write them down, that I needed to write them down. Partially for me, there's a lot for me to process. But also I just feel like the world sort of needs to know about this a little more. I talk a lot about how we don't tell these stories and what we lose because we don't. And that has just become more and more clear to me as I do this work, that that's a little too much to lose.
One of the things that I think you write about so beautifully in the book is this idea of stories and narrative, and that every patient has a narrative that they bring to the story, to their experience, and also the narrative that the doctors have about what's going on with them, and how that narrative is shaped and by whom has a huge impact on their care. Can you talk a little bit about that? And maybe there's a piece that we talked about that you might read that gives some sense of that.
So I think a large part of my book is about how narrative is power. It can be very therapeutic. A lot of people find a narrative that they can tell to be the healing. I have a narrative about how I was a good mom and I just couldn't, it didn't happen. Is a narrative that's more healing than, I chose to terminate. Those might be the same story, right? But it's a different narrative. I think what people don't realize is that in healthcare, your narrative is very powerful. It concretely changes the care you might get tomorrow. It will change the surgeries you are offered. It will change your outcomes. And so when we give up our stories, and we often do give up our stories, we're giving up actually a tremendous amount of power. On the other side of things, and this will be the reading that I get to in a second, is that doctors actually rely an enormous amount on narrative to talk to each other, to make sense of what we're seeing in front of us. And that narrative is both powerful and helps us heal, but also is something that we can get stuck on. And so I wanted to read this because I think what I like about this passage is it's relevant not to people who've had a baby, although also to them, but to any of us who've been a patient or encountered the medical system. I think this will ring true. Nora Salmon had one prenatal care visit with our hospital, just this week at 35 weeks pregnant. She did have a first trimester labs done somewhere else. From her purse, she produced a wadded up purple pregnancy passport that had a negative HIV test scribbled on her 12-week visit. But then she had a second HIV test done just last week on her first visit to our hospital. This is our protocol for patients in their third trimester, and Nora's third trimester HIV test was positive. Third trimester HIV is a risk for her, but also a risk for the baby. The baby can get the virus during labor and delivery and live with it its whole life. Or we can prevent that right now. The initial HIV test at the time we took care of Nora was a tricky one. It was known to be falsely positive a large portion of the time. Back then, this false positive result was frequent enough that it did not generate an official report because it was only a partial result. What it did generate was a reflex test called a Western blot, a more precise protein assay to tell us whether the result was real or not. When Nora came into labor and delivery, her Western blot was still pending, in process on the countertop of some anonymous lab. For right now, there's the positive partial HIV test in our hands and a woman in labor in front of us. If Nora truly had uncontrolled HIV, our doctors could have offered her a cesarean to minimize transmission to the baby. But they've got that crumpled purple paper from first trimester and her very clear protestation that she has not had any new sexual partners and her partner hasn't either. Nora is 100% sure she doesn't have HIV. No, she's 1,000% sure. The overnight team does not recommend a cesarean. Major surgery based on a probable false positive seems extreme. But they do want to do something relatively low risk, something that can offer the newborn protection from lifelong HIV. They start antiviral medications during labor. Antiviral HIV medications, like zidovudine, can prevent transmission to the neonate during labor and delivery. The plan is to stop the meds if her result returns negative. That's the plan. Morning comes, Nora is still pregnant. I join the team on the labor and delivery floor, rounding on the high-risk patients. I check the computer. The Western blot has a result. It is, as we have all hoped, negative. Negative, I sing out. That's wonderful. But then I look closer. That result's been back since 3 a.m. Why is she still on the zidovudine? The team hems and haws. The night team was too busy to discuss it, and the day team wasn't sure, and we wanted to talk it over. We wanted to be sure, you know? And I do know. Once you have a label, it's very hard to let go of it. Once you have a story, it's very difficult to change to another narrative, even if the story is false, even if you can point to digits on the computer screen that say this story is not true. Still, the absence of action, that not treating of that patient, came too hard for a team that entered with one reality and exited with another, just wanting to do the right thing and not sure enough to know what the right thing was. The patient was already exposed to the risks of the medication, right? So what's another dose or two until we make sure that everyone agrees that this is the new truth in the light of day? Let's turn off the zidovudine, I say. Everyone laughs, but nobody moves. In the end, I have to write the order myself. I ask the nurse if she wants me to push the off button on the IV pump, but she tells me that now I'm being silly. Am I say. Once upon a time, there was a woman with HIV. She came to us to have a baby, and we kept that baby healthy by giving large doses of intravenous medications. We were heroes, and we won. That is a story, but is it this woman's story today? No. The story changed, but we kept rolling forward, handicapped by our medical narrative, by the story we were telling. We kept our sword out, chopping at the dragon who long ago left the building, or perhaps never existed at all. If we get better at this, maybe we can figure that story out more accurately. Maybe we can figure out how to look at the dragon in the story. Are you the real enemy? Do we need to have this fight?
Thank you. That is a really powerful example of so many things, I think, of how systems work, of sort of the challenges between the doctors and the patients. And I think one of the themes that goes throughout the whole book that really struck me and really resonated with me, and back in my own work, even though my own work is very, very different, is that you write about this constant attempt to put women's agency and personhood at the center of the story. And in some ways, the story that you're writing about there is about not really trusting the woman as to what she says and what her kind of experience is. So what does that mean to you? Or like, how do you try to do that on a day-to-day level while also, being the doctor in that case?
It's actually really interesting because I think we do try to trust women, right? I do think that's an important thing. Listen to women is one of my favorite sort of maxims of this work. I do think it's also our responsibility to clearly state what's at risk here. And so often, I think we're actually seeing this on a really large level right now in terms of just whether we trust science or whether we don't, whether we think people are just saying things because they need to like cover themselves. On the one hand, I trust women. It's not my body, it's not my IV, and it's not my baby. But I have the visceral experience of delivering a baby with HIV. I have the real lived experience of having to tell a mother that. And I have the real experience of having to watch her deal with that for the rest of its life. So what I can't bring is the agency, and I shouldn't. But I think what I can bring is sort of the context and the reality. And what I think is really interesting is often people won't be able to hear me when I tell them this is the chance, this is the risk, this is the percentage. But if I say, this did happen, that baby is this years old, I wish we had done it differently, that is sometimes a more helpful narrative because then they can hear and decide whether they want it to be their story.
Mm-hmm. And how do you think about that question of sort of the systems that you need to have in place? That you write very beautifully about this, that you need systems to work for most people, but then it's hard to see the individual. It's harder to address the needs of the individual within that system.
It turned out my longest chapter was about medical systems. So apparently I have like a lot of thoughts that I've been waiting to share. And I think what's really interesting is that, first of all, we've all spent the last 6 months obsessing over whether or not our medical system is functional. Sorry, spoiler, it's not terribly. And whether or not we have enough ventilators in our supply chain. And so this is one of the ways where when people are like, well, I'm not a woman or I'm not having children, do I want to read this book? I'm like, I really think there's stuff here for everybody. I also think some of the stuff I talk about, which is how do you take care of people efficiently en masse? So you have to really create systems and language around them that's really standardized and maybe a little cold. And if you do that too much, they become objects, right? And I think this is something we sometimes see in other systems, maybe social support systems or even employment systems, right? Just the moving around of when the thing that is sort of produced and processed and tagged and labeled and moved around and even healed is you. When you're the widget of the system, it very quickly becomes anonymous and it feels bad. And what's funny about that is that it also has tremendous power. We can get tremendous things done when we systematize and standardize and anonymize, but then we also lose something and it feels bad. So I think all of us in all of our systems have to start to think about, when do you hit that point, where I'm losing more than I'm gaining? Maybe I've lost the soul of what I'm doing, but I don't want to lose the ability to, I don't know, transfuse blood when I need to safely within 20 minutes. So that's to me something that we always have to be thinking about, many of us in our work outside of medicine.
Right. The stakes are so high in the work that you do, so it's very visible, but it's true in so many systems. But then I think that there are the ways that we, that you work around that, and you talk about some of these things in your book too, sort of the way, the language that you use, or the ways that you try to think about patients as people and think about what role they play in getting to define. Like, for example, one of the things I found really powerful is where you talk about how often or not so often does the system think about how a patient is defining what success would look like, right? Like the system has to define success. This is what the outcome that you're looking for. But is that the same definition that the woman might have for herself?
One of my chapters is about morning sickness or nausea and vomiting in pregnancy. And the name of the chapter is, Did We Save Enough of Your Life? Because, this whole idea of nausea and vomiting in pregnancy long ago was something that sometimes would kill women, right? We didn't have IV fluid, in the 1800s. And some of the narratives from doctors in those times are terrifying. And then at some point, apparently around World War I, IV fluid was invented. It was able to give some hydration and maybe even nutrition to women. And so women didn't die. And right around then, sort of Freudian ideas were rising, and women who had really terrible hyperemesis of pregnancy, there's nothing anatomically that you can find wrong with them. It's like other diseases that we have, like migraines are my favorite example, where, we could look at a cadaver with migraines and everything would look very normal. And so it's very easy, if that's your definition of disease, to pretend it doesn't exist. And so they thought it was a neurosis. And they thought that a woman who was having, more vomiting was really rejecting the pregnancy. She was probably rejecting her partner. She didn't want to be a mother. And so some of the therapies around that were really about sort of like letting her sit and vomit, separating her from her family so that she would really understand what she truly meant inside her heart. And these are terrible therapies, and when we look at this, we are appalled. And in my chapter, what I go through is sort of what it's like now, right? If you're a young woman who comes to the emergency room and you're throwing up, and we get you some antiemetics and we get you to eat a cracker, and then we send you home. And then 2 days later, because you couldn't keep down the antiemetics we sent you home with, because of course you're not keeping anything down, you end up back in the emergency room. Maybe only after the 4th or 5th time does someone notice that it's been about a month since you ate anything, and that maybe we are not doing a good enough job. And then I will say that even after we notice that, and even after we put you in the hospital, and even after I sort of do everything I know how to do, and I know how to do a lot of things to make it better, you won't die. But I don't know how much of a life you'll have during that time. And maybe if that's something we thought about, maybe we would have better therapies. Maybe if we sort of valued women's suffering a little more. We care when they die. We sometimes even care when they get permanently injured. I'm not sure that we care enough when they suffer.
So many different places to go from there. I think that also raises for me some of the other really troubling pieces of medicine that you raise in the book, which is racial disparities. And one of the things that just, I think that your chapter on that is really, it's both very shocking and also a very powerful attempt to sort of reckon with the responsibility of doctors in that inequality and sort of just coming to terms with it. I mean, I think there's one line where you say that like the major factor that is going to affect a woman's pregnancy outcome is or her health during pregnancy, or her, I don't know exactly what the right word is,
Her
but
risk of death. Her risk
of death
just
is the color of her skin.
Yeah.
And we don't. It's such a stark fact, right? And one that I think gets hidden by a lot of other ways that we might look at data. Can you tell us a little bit about how you see that playing out, and how you think about it in your daily work, and then also how you thought about it to write about it? Because it's a really hard thing to write about, especially as a doctor and a white woman, and all the things that you are.
So I really didn't want to write that chapter for a very, very, very long time, because I sort of felt it was scary. And also as a white woman, it felt like maybe it wasn't my place. I think what I finally did come to that I felt really comfortable with, and I hope is valuable, is sort of a very personal reckoning, right? When we look at the statistics, it's really not controversial. Like, this is canon at this point. Black women die more than white women in this country in and around pregnancy. You can slice that data however you like. You can take college-educated Black women and college-educated white women. You can take, non-high school grads and college-educated. Nothing matters as much as the color of your skin. Nothing is as influential in your pregnancy outcome in terms of death as whether or not you are Black and white, right? And that's painful, because I work really, really hard. I really love my patients. It's very, very hard to think that the work I'm doing, the system I'm in, is so unjust. And I think we can talk about where I went with that. I talked a lot about implicit bias. Implicit bias is sort of the answer to this paradox. How can everyone I know mean so well as individuals, but then we look at the system, and the system has racist outcomes? I don't know anybody who's racist, and yet here we are, right? And the answer to that question has usually been implicit bias, which we can go into. It's sort of the small judgments we all make every day, without realizing it, many of them based on race. But what I wanted to do is that I felt like I was reading, and there were so many good solutions and so many good people working on this problem, and all of the answers were going to take 30 years, right? Let's get more Black women as doctors, absolutely. And I work with some of the most talented physicians I know are Black women. Let's make sure that people get sensitivity training and understand implicit bias, absolutely. I have to go to work tomorrow. I am going to do a 12-hour shift tomorrow. Tell me how to do that. Tell me how to go to work and feel okay when this is the truth of the system I'm in. And the answer for me is always, let's look at some stories, right? Let's look at the reality of walking through this, which is always more heartbreaking, but also more beautiful than I could ever tell you. But I can tell you a story of a young woman who died in our care. And I can tell you a story of a young woman who didn't, but who felt that we did not value her or her pregnancy or her family enough. And she felt that was true because she was Black. And I will tell you that she lost her pregnancy. And the next day she got up and she was wearing her own clothes. And the day after that, she went home alive and well. And that is a low bar. That is a really low bar. But we had not achieved that low bar before. And so you can imagine the feelings that I have and the feelings that she have around that experience are complicated and hard. And I don't think we're going to get anywhere until we feel them and talk about them.
Right. And do you have a sense of how, there's some things that may just never be aligned in that way, and that, like, what the doctor's expectations are or hopes are for outcome are not going to match what the patients are, because the patient is thinking about their individual case and the doctor is thinking about something different.
There's sometimes that we don't have aligned views, and sometimes, honestly, it is a matter of time, right? There's a matter of time where, like, the thing about pregnancy care is what I'll say is that there's no other part of your life, no other part of your healthcare where you anticipate joy. You don't anticipate going into your appendix surgery and coming out happier, fulfilled, and with a different role. Nobody else oversees a life cycle event except for maybe death, right? And so I think what happens is I say sometimes that like needing an MFM is kind of like needing an oncologist. Like nobody wants to need us, right? Nobody wants to need a high-risk doctor, although many people do, and most of those do fine. But
I did just because I have twins. So
there you go.
Yeah.
But what I would say about that is that sometimes also any of these things is never a single conversation. It is a real journey that we take together. When somebody who thought they were having, let's say, a normal pregnancy and was planning her baby shower in a month comes in with her water broken, right? So I've had many women, for example, be like, I want to leave the hospital because I need to go to my baby shower. Now, you and I, when I say to her that's not a good idea, it is not because I'm not understanding her values. I think what we are both doing is taking a moment to understand that the world has changed. And the life we were having is not the life we are having. And we're going to take a moment to mourn that life. And then we will figure out what to do next. So sometimes what I can offer is time and perspective.
It doesn't seem like the medical system is really built for time, though, these days at least.
It's hard. I'm going to tell you that it's hard. First of all, sometimes the things I do not allow for it. I work particularly in a specialty where sometimes you just have to go.
Right.
I don't mean you go without consent, but you often have to go really, really fast. And that is hard for somebody like me. When I became a resident, it was very hard because I'm a thoughtful, slow-moving person, and the culture and sometimes the necessity of OBGYN is you got to move fast. But I also think that it's not just time, it's revisiting things again and again. I tell a story in my chapter about informed consent, and this is a really, really common story about a woman named Amalia who came in at around 23 weeks with her water broken. 23 weeks is right at the border of when a baby can be born and survive. So we call it the peri-viable period. And that's a really complicated story to tell. But she decided she wanted everything done and she wasn't in labor. And we gave her antibiotics and we gave her magnesium and we gave her steroids to make the baby stronger. And we invited the pediatricians to come talk to her and everything was a flurry of activity. And the next day she was still pregnant. And slowly we started to de-escalate and we took away some of the medications and we moved her to a room across the hall where things were quieter. She was still pregnant. And 2 days went by and 5 days went by. Now she's 24 weeks. A week goes by, she's 25 weeks. She has 2 young kids at home, 4 and 6 years old, both of whom, by the way, had been term deliveries. So she expected that to happen again with nobody to care for them. And for the first few days, the church stepped in and maybe her sister for a couple of days, but they all had things to do. So finally her husband was staying home with the kids and then he got fired because he was a cab driver. He doesn't have FMLA, you know. I offered to write as many notes as anyone would need, but his cab company didn't care about my notes. And then a week later, she was still pregnant. She's 26 weeks, 27, and now they were going to lose their apartment, right? Because nobody's earning any money, and that's the way it works. And she told our team, she's like, I need to go home. And my resident, who knew what you're supposed to say, said, you can't go home. It's dangerous. The baby could die. You could die. You know, sometimes things change really, really quickly. You could get an infection. You could deliver a very preterm baby at home. You can't go home. And she said, I'm going home. And what I finally had learned after many years in this business is that I can offer what I have, right? I have $1 million to offer her. She can stay in my house forever. I will feed her. I will clothe her. I will shower her, provide expensive medication. You cannot even pay for the amount of brain cells that, you know, are going to come think about her and talk to her and work on her. That's not what's right for her life. She needs to go home because she's a 6-year-old and a 4-year-old and because they're about to lose their house. And so after I talked to her and said, you could, I don't think you will die, but you could have this experience where you deliver at home. But I hear that you can't stay. I hear that. Let's talk about what we can do. If you go home tomorrow, I'm in the ultrasound unit on Wednesday. Can you come back on Wednesday for an ultrasound unit and temperature check? Yeah, I can do that. Can you try to make sure the next door neighbor can take your kids real quick if you need to come? You know, not all the time, but just in case. I don't want you to hesitate. Yeah, we can work on that. Okay. So she packed up her room. And as she was walking out the door, she'd been with us, 4 weeks by then? She said to me, bye. I'll see you Wednesday. And I said, you're welcome back anytime. Anytime, just come. We'd much rather have you here with us. And she said, I know, but I'll see you Wednesday.
And
and you know what's terrible is I don't know. I don't know, but I do this, this story is a story I will tell you right now. In my hospital, there's probably 2 women with this story.
Mm-hmm. Right.
Next month, there will be 2 more.
Right. Well, and I think that there's, I want to get back to the informed consent thing too, but one of the things that really came through to me in the chapter about race, which I think is connected to this question of what decisions are right for which people, is we talk so much about systemic racism and having to understand racism as a system and thinking about the way that it's institutionalized. And I think we can certainly see that happens within medicine. But it's really important to be able to see social problems as systemic, right? Because then we understand that it's not like a quick fix. One person does something different, or you just have to be nicer, or, all the kinds of things. We wish it were that simple, but actually changing systems is really hard. And you have to understand how the systems work and how to make changes that are going to work. And it's really important that we think about things in that way. On the other hand, when we think about things in that way, we sometimes lose the person, right? And we lose our own agency within those stories of the ways that we can be responsive as people to one another. And so I thought that your chapter on race did a really beautiful job of acknowledging that it's a systemic problem and then talking about, okay, so then how do I as a person not just say, oh, it's a huge system and I can't fix it. It's going to take 30 years. So we'll just keep, chipping away in our little way and we're doing the best we can. But really bring it back down to yes, it is systemic. And yes, we are all people who are part of this system and have to own the ways in which we are helping to build that or take it down in little ways every day.
Do you know what that reminds me of? It reminds me of, that Jewish saying, in one pocket, keep a saying like, I am the whole purpose of the world that was created for me. And in the other pocket, keep a saying that says, I am nothing but dust, right? Like there's very little you can accomplish and there is no end to what you can accomplish. You can also do a tremendous amount of damage, by the way, by not realizing how much power you have in a room. This is something I work a lot with my new residents on. They don't always realize, wow, they're so low on our totem pole, they still have so much power. Mm-hmm. So I think there's a lot of virtue in both realizing that you can do good and also, honestly, realizing that even sometimes not doing bad is a lot to ask.
Right.
Yeah.
Right. Can we talk a little bit about the circumstances in which you are practicing medicine these days and what it has been like? The impact of
sure.
COVID on maternal fetal medicine and what your experience has been with all of that.
We could absolutely talk about that. This has been my life since my book came out March 7th and like March 9th, the world shut down. And March 23rd, we went to a COVID schedule, which I refer to as our wartime schedule. What's really funny to me, and I think it's so emblematic of sort of how people feel about women's health, is that I said to people, I'm on the front lines, and they'd be like, aren't you on like the wrong end of the hospital? And I feel like this is the moment where I say to them, women's health is human health and human health is women's health. And so if there is COVID in New York City, then there are women with COVID. And if there are women with COVID, then there are pregnant women with COVID. And if there are pregnant women with COVID, the person who's going to take care of them is me and my team. So my experience was one of tremendous fear and anxiety because it was pretty clear to us from the very beginning that we were like a lot stupider than this virus. Basically, like we were still asking questions about travel to China and Italy when it was pretty clear you could get it from down the street, right? We were having I think the CDC was just having slow implementation of PPE, and there's a lot of concern that we didn't have enough. And so, for example, we were told you only need it for aerosolizing procedures. So outpatient, I don't do any aerosolizing procedures. And then 1 week, my entire outpatient staff, boom, everyone's out with a fever. Like 10 pins, they all went down. They're all back, they're fine. Scary, right? I feel like we were just so stupid for so long. And it also led to a tremendous amount of mistrust. I think it's a mistrust we're all still feeling. No masks, now you're a bad person if you don't wear masks. There was a lot of stuff that happened because of PPE. PPE makes you a different kind of doctor. the week that COVID really came to New York City, I was doing outpatient. So the next week I was on inpatient. And the first week we had tried to protect our trainees. We had our residents like not going into rooms. And by the second week it was too much. We couldn't keep up. And I remember I came on one night and there was a woman with COVID pneumonia who was about, let's say, 28 weeks. So pretty advanced in her pregnancy. And these women got pretty sick. I just want to sidebar and say it was really, really stressful to take care of them. I work in a specialty where I am very used to taking care of women and offering sort of suboptimal alternatives with very little data behind them. I will often start a conversation with none of our choices are great, right? And so there are ways in which COVID should be comfortable. I've never before had to navigate care with so little guidance. I had one study of 9 women out of China by the time our units were getting full. It was really unclear what to do for them, how to do for them. When do we deliver a woman who's about to be intubated? Do I give her a preterm baby? Am I making things better? Am I making things worse? I had no guidance, right? It was hard. I didn't do any of this alone. I work with the most phenomenal people. I think some people find this funny. We started a WhatsApp group for our division, and it is tremendously active. We met every day on our WhatsApp group. And some of it was just true, like, what are we doing about this? Are we anticoagulating all women who were COVID positive? What if they were asymptomatic? And some of it was just, I can't be alone. I am having to make terrible decisions. I'm having to admit to people that I don't know, which I'm very comfortable with, but to tell somebody who's very sick, I don't know if this will help. It is a hard thing to do again and again and again. And so to have company is a beautiful, beautiful thing. But when we were working, so I was admitting that 28-weeker, right, who might get sick, who will probably not get sick. Most women didn't get sick, but some women did. And the resident told me about her. And I was like, okay, let's go see her now, right? And I had been out of the inpatient unit for maybe 10 days, right? 10 days of the beginning of COVID. And the resident looked at me with shock. She was like, I just saw the patient. I told you about the patient. We have 6 gowns left on this floor until tomorrow morning. Really? And I was like, I've never been that doctor. I'm never the doctor who doesn't go to see the patient. It's a terrible kind of doctor. I never wanted to be that doctor. This is the doctor I have to be tonight. I had to call her on her phone to talk to her about a premature baby. I don't think she ever saw my face. So it changes your relationship to medicine. It changes your relationship to patients. And I also feel like it was a tremendously heavy burden to bear of all that uncertainty. And then there was the part where I was just really, really scared about bringing it home. I think I spent the first 2 weeks in a pretty chronic panic attack. I have woken up every day healthy. I never got sick. It is not because I'm really great at PPE, because I'm really not great at PPE. I have a major breach every shift. I have been lucky and I have been blessed. And my partner has stayed healthy, and so have our kids. I have a lot of friends and colleagues who left their families for this time. I think one of the things about working with young women, the sacrifices are large. Some of them left young children. Some of them left nursing infants, so that they could come to work and take care of people.
Well, thank you. That is huge. Yeah.
I didn't do that. I stayed with my family. My husband was adamant that everything would be okay, and it turns out so far he's been correct.
It's good to live with an optimist.
One of us needs to be, right?
Yeah, exactly. Well, I'm so glad that you have been well, and hope that that will continue to be the case, of course. It is very interesting to hear about the ways that there is still such, I mean, there are so many disconnects and sort of so much cognitive dissonance in all of this, but to think that, you know, there is still a sense of not even, that even in the midst of something that is so global, there is still a kind of marginalization of women's health within that, you know, sort of not understanding that that's going to be relevant.
Yeah.
And that it infiltrates all parts of medicine.
We have to remind doctors all the time. We have to remind, I have a terrible story before COVID, which is that I was a medical student and we were on labor and delivery, and a woman her heart stopped. So in the hospital, and someone's heart stops. This does not happen on labor delivery very often. We work with young women, they're healthy. But in the hospital, when somebody's heart stops, you call a code. The code is like a bat signal. It goes out to all these various people in the hospital who come and help you. We called the code, and we started doing chest compressions, and we started trying to find, to give her air, and nobody came. Nobody came for a minute, and nobody came for 2 minutes. And it turned out that the code had gone out saying cardiac arrest, labor and delivery, and not one of those people knew where labor and delivery was. And when they figured it out after 2 minutes, and they all came running, racing to the 7th floor, that door that was always locked, that mysterious door they had never been through, none of their IDs worked in our door. Because, of course, IRDs had a special system so that nobody could steal a baby, which is very important and a worthy cause. But still, perhaps somebody should have thought that perhaps we might need the wider resources of the hospital. And so they banged on the 7th floor door until somebody heard them and sent the medical student to let them in. And that woman was fine, and her providers were fine, even though we all had more gray hair after that. But no, that 3 minutes was foolishness, right? That's foolishness because nobody thought of us. I think so part of what my job is at work is to often raise my hand and go, so hi, in the ICU, I just want to know, are you able to accommodate a pregnant woman? Do you have a fetal monitor? What are we going to do if? Maybe we're only 1% to 2% of the population, but it's pretty important 1% to 2%.
Right. And I'm sure that came up a lot during COVID also, just sort of making sure with all of the ways that you're trying to accommodate patients to make sure that
we had to be ready for anything, right?
Right.
So we just had to expand everybody's view of what anything could include.
Right. So one of the questions, I don't know exactly how to ask this, but I was thinking about this when you said that you work with a lot of young women who had to make hard choices about whether to go home to their families during COVID or not. And I'm just thinking a lot about how the whole field changes when women are the maternal fetal medicine doctors, and how being a woman living in a woman's body, showing up on the labor and delivery floor as the high risk, specialist, how do you think that has changed, or do you think, I'm sort of making the assumption that it has changed the field, but what would you say about that? Do you think that it has changed the field, or in what ways?
I have so much to say about this. More and more women are becoming doctors. Women's health particularly is populated by women doctors. Still, if you look at who are the chairs of departments, it is not all women. So it's sort of very marked.
And I'm sure the higher the specialists go, there are more men.
Yes. I also want to say that I guess I'd like to make a vote for co-ed women's health providers, I guess. There's a couple things there, which is that I don't think it should be all men, but I also think that when it becomes all women, first of all, I wish this weren't true, but society starts to devalue it, right? All of a sudden salaries go down, research money goes down. I think we have really phenomenally important things to take care of and interesting things to take care of. I sort of want the best brains. I want all the best brains working on my problems, right? So there's that. And I also would like to say that I do think that there is a sensitivity of the representation. There is also humility that comes from knowing that you do not know that experience, that you cannot know it. And that's also really valuable. And I think sometimes if you have the right people, like the right men, or maybe the right white people, if we're talking about Black people, or the right any outside group, you can sometimes really get a beautiful humility, which is not instead of, but maybe in addition to representation, can really do some beautiful things for your field. Mm. But I still think that there should be more female department chairs, and I am available if anyone's looking.
Yes, well, as you said, these things take a lot of time, but it is kind of astounding to see the ways in which patriarchy is slow to disintegrate, or
to get to unclench.
Right, exactly. I know that you and your family lived recently in Israel for 2 years. I'd love to hear a little bit about what you saw in terms of cultural differences in the practice of maternal fetal medicine while you were there.
Wow. So when we lived in Tel Aviv from 2017 to 2019, I had a very different life. I wrote a book I went surfing whenever I wanted to, and I ate green shakshuka in amazing cafes. But I also worked in a hospital, and I really thought I was going to go work in a big fancy Tel Aviv hospital. But like many sort of immigrant experiences, I ended up absolutely not where I thought I'd be. I ended up at a tiny Haredi hospital in the north, and I did not want to work there. I thought it was going to be terrible. I spent so much time talking about women's agency, and I did not know if I could work in a hospital where women call the Rebbe before they decide if they're going to have an induction of labor. I didn't want to be part of a system where women couldn't make their own decisions like that. It's part of why I've never wanted to take a job in a Catholic hospital. I never want to be in that situation. And so the story I tell about that is that the first day I walked in, I don't think I even got oriented. I don't think I ever got oriented. They just sort of threw me in there. And
very Israeli.
It was so Israeli. And with my Hebrew was okay, but it was definitely not great. And the first day there was a woman who came in and she was 23 weeks and her water was broken, right? So this is to me like the most complicated situation. We have to talk and talk and talk. I have to understand her needs. But also I was really scared that she was going to ask the Rebbe. And I was really scared that the Rebbe was going to say that she needed to stay pregnant no matter what, even if she got a fever, even if she got infected, even if she was going to die. I know that Judaism doesn't think that. I know that. But I also know that the Judaism that this Rebbe practices might be different than my Judaism, and I just didn't know where I might go. So I walked into the room, and with my not terribly great Hebrew, I said to her, before we start anything, what you need to know, you're the most important person in the world. Okay? So whatever else we do, we cannot let anything happen to you. So I said this, right? Because I'm like so heartfelt. I'm like, I don't know if I'm going to make it at this job. I don't know if I'm going to make it through the day. I cannot let anything bad to happen to her. I cannot let her let anything bad to happen to her. And I look up and she gives me this big smile. And she says, B'diuk ma she'Rebbe amar. That's exactly what the Rebbe said. And I just was like, I can work with that.
Right. That's great. Thank God.
We can start there.
For that day, that was the right Rebbe.
That was all I needed. There's only one. We'll talk about it another time. It is a very complex society, and many books can and probably are written about it. I loved working there. I loved working with the women there. They were thrilled to have a female doctor, actually. There are not a lot of female gynecologists, obstetricians in Israel, and especially they adored me and I adored them. It is also very interesting to watch women create agency where there isn't. It is very interesting. It is not a system I would vote for. It is not a system I could live in. It is also not as simple as you would believe. The other thing that was really interesting, we can talk about how midwifery based it is. There's a whole bunch of stuff, but I will also say that what was really wonderful for me about this hospital is that about half my residents were Palestinian Israeli women. The most requested surgeon by the Haredi community was a Palestinian Israeli man. Right, you could not make it up, but that is the sublime ridiculousness of Israeli life. There was a diversity there, where like the settler woman would drive to be treated by the Palestinian resident and see no problem with that. They would sort of be very congenial. That I think was really strange and beautiful. But the other thing is that this Haredi hospital, because Haredi women really try to avoid C-sections, it's kind of crucial if you're planning on having, let's say, more than 12 or 13 babies, had this real reputation for natural non-interventional birth. And so half of the patients were Haredi and half the patients were like tattooed Tel Avivi, city people like myself, who had driven past much more intellectual academic hospitals to get to our little hospital to have their baby in our birthing center. And you know what? And everyone got taken care of.
I love that. I think it's so important, to hear about reality on the ground in Israel because we get a different view here in the States. Sometimes.
Yeah, it is not easy. It is not perfect. I don't want to whitewash it, but I do think that there is, when you get some people in a room and they just have to get something done, it is amazing how they're just people sometimes.
Right. And especially I think in moments of these liminal moments where it's like, this is it. This is life. As you said at the beginning, it's like, these are these essential moments. And,
right.
everything else in some ways. I mean, nothing falls away, but everything falls away. You know, it's like people are.
I think medicine is like that. Medicine is really concrete. There's poop and there's urine and there's pain and there's blood. And the truth of the matter is, if you know how to take an x-ray, you have the job, you know? So there you go.
Right.
It's true.
And those are things that everyone shares also. It's like, it really cuts you down to those human basics.
It's true. I mean, it's true in America too. My world was widened considerably when I entered medicine.
So talking about the patients looking for more natural births, this is a good time to bring in a question from one of our audience members about how you feel about the trend to home births.
Ooh, you guys start with the easy stuff, huh? Okay. All right. So here is what I think about home births, and actually it's part of my chapter. Do I think home births can be safe? I do think they can be safe. Do I think home births could be safer? I think they could be as safe as hospital births. What I think that people don't realize is that home births in the US are not part of the system. So if you're at home and things are not going well, you don't have a doctor who your midwife can call and say, should we come in now? You don't even have a doctor who your midwife can call and say, we are coming in now. My experience with home births is almost exclusively with home births that have gone bad, right? That's how they ended up in my hands. But I will tell you, there's friction. There's friction from coming in from outside the system to going inside the system. And that friction is time. And that friction is problematic because of that. There are other countries where home birth is part of the system, where there are clear protocols for when can you stay home and when you need to start heading in. There's clearly a physician who's responsible for you when you show up. There is a clear, plan for transport from home to the hospital. Then I think we can talk about doing it safely. But in America, for better or for worse, right now, in most places, to do a home birth is to opt out of the system, and you cannot always opt back in when you need to. Even in some of the most famous birthing centers like Ina May Gaskin's, they transfer 15% of their women, right? I just don't think we're in a place where it feels safe to me. That being said, I have a tremendous amount of empathy for women who really felt like they had no choice but to leave the system to get what they needed.
I think also some of it has to do with risk tolerance, right? And sort of how people understand what risks they're willing to take or where they see themselves in statistics. And that's so different for different people.
That's true. It's really personal. But I also think there's something really philosophical here, which is that there's a tremendous desire to believe in your own body and its own power. And I think that's really, really true and important, and something I've really learned from the midwifery and home birth community. It also sometimes means that there's a delay in noticing when something is going wrong. Mm-hmm. And I think what's very hard is that you have to hold both these things in your hand, right? Your body's amazing. This is almost always fine. Your body can do this thing. And at the same time, you have to know sometimes it's not. Sometimes everything is not okay. I need a plan for that. And I think part of this is, to me, sometimes a cultural difference between these two worlds. The world of medicine, where I come from, which is, if something's not going to be okay, I need a plan right now. And maybe we should just get out now, because it might become not okay later. And we don't even want to get close to that. And then the midwifery community, which is like, this is going to be fine. This is human. And maybe we need to meet in the middle, because I think it's also the language about sort of bodies and capability and power. That's really a culture clash as much as anything else.
Yeah. Well, this reminds me of something else that you wrote about, which is, so much of the kind of feminist understandings of health and women's health has to do with informed consent, and is about this idea that knowledge is power, right? So like women should be allowed to know. They shouldn't be, as has happened for so many, centuries, kept from the truth about their own bodies and experience, which is very paternalistic. And we have so many, I think we probably all have those stories, and certainly women of other generations had even more stories about doctors who sort of, condescend to women, are like, oh, don't worry your pretty little head about that, or you don't need to worry about that, or whatever. But you write also, what?
You go to sleep, wake up with a baby.
Exactly, and you'll be happy. But I think you write about something which is really interesting and complicated, which is that sometimes people don't want to know. And so where does the kind of idea that knowledge is power and the idea that you want to have women make their own choices and have agency, where does that,
Yeah.
or
Well, I
conflict?
mean, I talk about this a lot in my chapter about genetics, where basically I had a patient who came to ultrasound, and she had clearly come to ultrasound as a celebration of her pregnancy, right? The fact that it's our diagnostic experience and we're trying to look for problems was not why she was there. She was there because she wanted to get a cute picture for her fridge. And then I saw something wrong. I saw something really wrong in her pregnancy. Um, and she didn't want to hear it. She got really mad at me and she left. And she didn't get genetic testing, and I have no idea what happened to her. I'm sorry, a lot of my stories, I have no idea what happened to people because they're real, and that's what happens in real life a lot. And for a long time, I thought that, I had done a bad job sort of getting through to her, but that she would live to regret it. Do you know what I mean? That she wouldn't know what she needed to know. And I think that might be true, but I also came to sort of believe that maybe she has the right to not choose the knowledge. Maybe it's not my job to impose that on her. Maybe I can respect that. One of the related things that comes up a lot is I say sometimes too much information is as misleading as too little. Like you can lie just as well through information overload, right? I have a
Right, can
couple.
give you a sense of control or something that is not real.
Or even like so when my example is always that like when we do consent for a C-section, we talk about the risks of surgery, which are generally for any procedure, bleeding, infection, and damage to organs. And in one of the institutions I've worked at, they also consented you for death, that it had a higher risk of death. And this is true that a C-section is more risky than, let's say, sitting in your chair. But it meant that I had to pay, but it's very not risky in the scheme of like generalized, like it's still hundreds of thousands of women undergo them for every woman who dies. And I had a woman who came in bleeding from her placenta previa, and she was hemorrhaging, and she refused the C-section because she was like, well, if I'm going to die, I may as well die right here. I'd rather die with like, in this room, it seems more comfortable, right? We had lied to her, right? Because we had given her the impression that these were like sort of equally dangerous experiences when clearly I could save her life. That's an extreme example, but I do think this happens a lot in medicine where we just sort of, in our attempt to give you what you need to know, we sometimes give you so much that it's impossible to know. And so I think actually to me, this is sort of where the like pastoral experience, and I guess I mean it like really pastorals and guidance experiences, is that for me, it's also about knowing like what are your values, what are we trying to get to, and can I give you the information that helps you make those decisions? You might not need the information about certain kinds of genetic testing if, let's say, termination is not in your vocabulary. Well, then we don't have to talk about that because that's not who you are. But somebody else really should, because that is who they are.
Right. You had this line that I thought was really just so smart where you said, I would rather know, I just would want to choose the conditions of my knowing.
Yeah.
And I thought that was really just such an interesting kind of way to nuance it, of sort of, that yes, ultimately it is better to have the knowledge, but you want to have some framework for being able to even understand the knowledge or hear it or accept it. And I think it gets back to that question of the different stories that people are telling, like the example that you give with that patient. Like the story she was telling about going to have that diagnostic ultrasound didn't have anything to do with diagnostic anything. It had to do with like a photo shoot.
Yeah, it was a photo shoot for her. And there's ways in which that's demeaning to me and my like literally years of education and like millions of dollars of brain cells that I'm walking around with. And there are ways in which that is absolutely her prerogative, man,
Right.
And I'm so glad I can bring people joy. What you do when my conception of what we're doing and her conception of what we're doing clash. I think what I said in the book is it's what happens when an irresistible force meets an immovable object and it goes boom.
Right. And I think, there's some interesting comments from participants about sort of, what the source of information is and what the purpose of information is. And I think about informed consent, which was really something that we got to because of amazing women's health activists like Barbara Seaman, who was the person who pushed for there to be the first patient insert on a pill, which was the birth control pill, wanting to warn women about some of the dangers of progesterone and women's, taking hormones in general. But now what that's turned into is like, something that's either said very, very, very fast at the end of a commercial, or something that's such teeny tiny script that no one even looks at it. And it basically serves to like cover the asses of the companies, right? So, you write about informed consent as being something that can't just be something you sign or something, a piece of paper you're handed, but a relationship, something that has to be built on understanding people. Yeah. But that is a whole different ballgame from what informed consent has turned out to be. So I appreciated that attempt to get back to what it was about, which was recognizing that patients are people, and people who are having particular, who deserve to be treated as human beings who will get to make some of their own decisions, hopefully.
And also it gets back to like, what about those women who don't want to make their own decisions? They want to call the Rebbe. For that too, I came to the belief that this gives them solace. I don't believe in it. I don't understand it. I don't really approve of it, to be honest. But that's not my decision either. I cannot make them take that autonomy. Do you know what I mean?
Right.
This gives them comfort, so it shall be.
Mm-hmm. Well, thank you so much, Chavi, for being with us tonight and for sharing your expertise and your experience and your sensitive questions around these issues. There's so much more to talk about, but I really hope that people will read your book if they haven't already, because you go into so much depth, and it's really just a very beautiful and smart and just provocative book. And we just put the link to bookshop.org where we encourage you to buy it. Thanks to all of you for joining us in this conversation tonight. I hope to see you back here next week, same time, same place, for a conversation with Jennifer Rosner about her new novel, The Yellow Bird Sings. We realize that the discussion next week will be coming at the tail end of Tisha B'Av, but since the book is about the Holocaust, we felt it was thematically relevant, and feel free, if you are fasting, to bring your break fast to our conversation. For those of you who are new to JWA tonight, I hope you will check out the many, many resources we have in our digital archive at jwa.org, from online exhibits to lesson plans to primary sources to our podcast, our blog. We have so much material to discover and to help you hopefully gain insights about history, about role models, about understanding the world that we live in today. So please check that out. And until next time, be well, everybody. Thank you. Good night. Stay healthy. And thank you again, Chavi.
Oh, thanks so much for having me.
That was wonderful. Good night.
Good night, everybody.